Thank you, Sendil, for kind introduction, and thank you, KSM, for inviting me for the lecture. My topic today is acute pulmonary embolism. So, what is pulmonary embolism? That is obstruction of the pulmonary artery or its branches by a material. Could be thrombus, could be tumor, could be air or fat. It should be originated elsewhere and should come and embolize to the pulmonary arteries. So, today we will discuss about the thrombus generated pulmonary embolism mainly. So, pulmonary embolism itself carries a high risk of mortality. So, it is very important to accurately diagnose and initiate the management promptly. So, incidence is around 40 to 115 in 100,000 population in US. The main problem is 34% of them will die suddenly within a few hours before therapy, and 59% of patients will die with acute pulmonary embolism, but it is diagnosed after the death. So when it is come to the management, predisposing factors are very important because it will predict the probability and the risk of recurrence and the decision for chronic anticoagulation. So predisposing factors can be divided into three categories: strong risk factors, intermediate risk factors, and low risk factors. Under strong risk factors, fracture lower lip, hip or knee replacement or other trauma, other conditions will come. Under intermediate risk factors, these conditions like atheroscopic knee surgery, central venous lines, autoimmune disease, etc. will come. Under weak risk factors, bed rest for 3 days, diabetes, hypertension, and long immobility due to prolonged traveling will come. When it comes to pathophysiology of the pulmonary embolism, due to the mechanical obstruction of the pulmonary arteries, it will lead to obviously ventilation perfusion mismatch. Then it will lead to hypoxia. At the same time, there will be a mechanical obstruction to the right ventricle. So suddenly right ventricular pressure will go up due to mechanical obstruction, and at the same time vasoconstriction due to hypoxemia and occluded pulmonary arteries. It will further increase the pulmonary right ventricular pressure. So it will lead to right ventricular failure. So most important thing is this is the primary cause of death in these patients. So it is rapidly progressive syndrome. It is eminent with in the systemic as a systemic congestion and hypotension. So this diagram showing the vicious cycle of right ventricular failure leading to right ventricular enlargement and reduction of output, leading to reduction of left ventricular filling pressure, and then it will cause reduction of coronary flow. Then it as a vicious cycle, it will affect right ventricle further with ischemia. When it comes to diagnosis, as I mentioned, it should be prompt. We have to have a good suspicion at the presentation about the pulmonary embolism when patient is present. The problem is the symptoms and signs are non-specific. Patient will come with dyspnea, chest pain, presyncope or syncope, hemoptysis, haemodynamic instability, and other important thing, patient may be asymptomatic. If it is chest pain with a distal pulmonary embolism, chest pain may be pleuritic type. If it is anginal type, most of the time it is due to central pulmonary embolism leading to right ventricular ischemia. Here we have to think about acute coronary syndrome and aortic dissection as differential diagnosis. Then chest X-ray and ECGs are widely available bedside tests. Chest X-ray is very important to exclude possible differential diagnosis like pneumonia, pneumothorax. We can happily exclude with the chest X-ray. In ECG, it will show the peculiar features of ECG S1, Q3, T3 pattern as I shown in the picture, but it is not always common. At the same time, it is not that rare. Most of the time, patient will be tachycardic with atrial arrhythmias like atrial fibrillation and right bundle branch block also can be there. But if the patient is present with unexplained atrial fibrillation, we have to think about possibility of pulmonary embolism too. Then when we are going to diagnose the patient, we have to lay down the investigation plan. For that, it is very important to check the patient's pre-test probability. If the patient's pre-test probability is high, we have to go for the CT coronary angiogram. If it is low, we can go for the D-dimer test. So it should be done with a combination of the clinical findings, predisposing factors of the patient. This can be judged with the, solely with the clinical judgment or that prediction rules like Geneva score and Wells score. This is revised Geneva score. This is Wells score. All the predisposing factors included there to calculate the risk. Through them, we can divide into probable pulmonary embolism, non-probable pulmonary embolism, or high risk, intermediate risk, and low risk categories. If the patients having low risk, we can go for the D-dimer testing because D-dimer test has a good negative predictive value. D-dimer may be positive whenever there is a thrombus in the body. So if it is negative, we can happily exclude. But if it is positive, we can't confirm the diagnosis because cancer, infection, inflammation, pregnancy, etc. many causes can give rise to positive D-dimer test. Then CTPA, computerized tomographic pulmonary angiography. Multi-detector CTPA is the investigation of choice to diagnose the CTPA, pulmonary embolism. It can visualize up to subsegmental level. It got good sensitivity and specificity. Then lung scintigraphy, that is ventricular ventilation perfusion scan. It can be used in special conditions like pregnancy, contrast-induced anaphylaxis, and severe renal failure because it involves low radiation and low contrast. Obviously, there should be a ventilation perfusion mismatch due to the mechanical obstruction. It is used here. Pulmonary angiography, nowadays it is not much used. When we inject the contrast medium in the X-ray, it will show filling defects if there are thrombus there in the pulmonary arteries. Then the most commonly used test, echocardiography. It is very much useful in pulmonary embolism situation. First thing, it can differentiate from similar conditions, differential diagnosis. We can exclude them with the echocardiogram. If patients present with chest pain and haemodynamic instability, we can happily exclude pericardial tamponade, valvular dysfunction, LV dysfunction, aortic dissection, hypovolemia. Those can be excluded with the echocardiogram. At the same time, it's a fast and reliable informative investigation about the right ventricle size and function. The problem is if the echo is negative, you can't exclude pulmonary embolism. This is a picture showing echocardiac images with pulmonary embolism. It will show enlargement of the right ventricle, pushing of the intraventricular septum towards left ventricle, and IVC will be distended because of the volume pressure overload in the right side of the heart. Very rarely you can see thrombus in the right ventricle. If it is there, you can diagnose directly with the echocardiogram, but it is very rare. Then if the patient is hemodynamically unstable and bedside echo is available, we can do the echo directly and look for the right ventricular volume pressure overload and dysfunction. If it is not there, we have to look for other causes for patient's instability. If it is there, the chance of pulmonary embolism leaded hemodynamic instability is there. So when the CTPA is not readily available, if patient is rapidly deteriorating, in that situation, even thrombolysis is indicated with the echo parameters. Then DVT scan, compression ultrasonography. It can diagnose DVT, deep vein thrombosis. It is usually prevalent in 70% of patients with pulmonary embolism. And it got good sensitivity and specificity. The most important thing, it warrants anticoagulation in these patients. when we combine DVT scan and echo, we can go for good and we can increase the specificity. This is the algorithm with suspected high-risk pulmonary embolism patient. If patient hemodynamically unstable, we can do, as I mentioned, bedside echo and look for the right ventricle function. If it is not, if right ventricle is okay, we have to think about other cause for hemodynamic instability. If it is there, we can do CTPA to confirm the diagnosis. Then if the patient suspected to have pulmonary embolism but hemodynamic is stable, then we are going to that predictive rules and check the probability. If patients have low probability to have pulmonary embolism, we can go for D-dimer test to exclude. If patients have high probability for pulmonary embolism, we should go for CTPA, not the D-dimer. Once diagnosed, at the same time, you have to assess the risk of death, early death, because pulmonary embolism having high risk of death. It is third to the, it is called third, the most common cardiovascular condition. It is second to myocardial infarction and stroke. So hemodynamic instability per se, patients having high risk of death. So if patient stable hemodynamically, then we have to look for the other parameters to assess the prognosis, especially early hospital prognosis. So once patient hemodynamically stable, we have to look for right ventricular dysfunction. It can be assessed clinically with imaging and or with laboratory markers. At the same time, we have to look for comorbidities and aggravating conditions which are associated, causing more, making patient's prognosis worse. The hemodynamically unstable patient can be divided into three categories: a patient with cardiac arrest, or patient with obstructive shock, or patient with persistent hypotension. Then, when, as mentioned, if the patient hemodynamic is stable, then we have to look for features of right ventricular failure. Clinically, systemic congestion may be there, patient will be tachypneic, tachycardic, low blood pressure, syncope. These things common with right ventricular failure. Then with imaging, echo will show the features of right ventricular failure and distension. And if there is a patent foramen ovale or small ASDs in the echo, it will show right to left shunting. So this is also a prognostic sign. Where one thing is it will cause severe hypoxemia. Other thing is it will increase the ischemic stroke due to paradoxical embolization. CT also will help to assess the right ventricle. It will be enlarged in the CT compared to left ventricle. Then other than the imaging modalities, we can look for the bio markers to assess the right ventricular injury and dysfunction. So high sensitivity troponin and heart type fatty acid binding protein. Those two will be elevated if there is myocardial injury. So prognosis will be worse when these are positive. Then markers of heart failure, B-type BNP or NT-proBNP. We can use these. These are elevated with myocardial stretch. So if it is positive, it leads to worse prognosis. Then other lab parameters like lactate, serum creatinine, neutrophil galactonase, hyponatremia, vasopressin, these things also showing the hypoperfusion. So these are also good markers of prognosis. So not using one by one, we have to combine all these markers, imaging and clinical scenario and predict the outcome of the patient. So especially if patient's hemodynamic is stable. So right ventricular dysfunction in the echocardiogram with positive troponin. So it guides the early therapeutic decisions because the worst prognosis is there. Then the other aggravating factors and comorbidities. For that, there are some calculations and this pulmonary embolism severity index, that's a PESI, that is extensively validated score. It can assess the patient's comorbidities and calculate the prediction. So, high-risk patient will have urinary instability, other clinical things like comorbidities and right ventricular dysfunction and elevated troponin. So then after diagnose and after assessing the severity of the disease, we have to lay down the management plan. So it can be done in the emergency department, then treating the acute right ventricular failure and hypotension, and specific therapies like anticoagulation and thrombolysis. Then hypoxemia is very common, as I mentioned, because VQ mismatch. So we can give supplementary oxygen. High flow oxygen also can be given. If you are going to intubate, the patient should be very cautious because anesthesia induction severe hypertension is very common because of this mechanical obstruction. So you should be cautious, if possible, better to delay. And the most important thing, correction of hypoxemia won't be possible without reperfusion because of the mechanical obstruction already there. Then when it is come to CPR, most of the time pulseless electrical activity will be there in the monitor. It's an unshockable rhythm. So we have to adhere to all the life support guidelines. At the same time, should do the early decisions of thrombolysis if you are suspecting pulmonary embolism in the arrested patient. And good for thrombolysis, it should be a bolus. Most important thing, CPR should be continued at least 60 to 90 minutes before termination. Then when it comes to the pharmacological treatment, generally we have to correct the blood pressure. We can use volume expansions, but should be cautious because volume loading will further stretch the right ventricle, leading to compress the left ventricle. Then it will reverse the blood pressure. So should be cautious and should monitor the central venous pressure if possible. Then as vasopressor, norepinephrine as good place for as inotrope. It will increase the right ventricular inotrope and increase systemic blood pressure. It can be combined with dobutamine, but it got its own risk. If ECMO is available, we can use it. Once stabilize the patient, at the same time we have to start the specific treatment like anticoagulation. For patients with high risk and intermediate risk, we have to start the treatment when it is suspected itself. We should not wait until it confirmed with the investigations. So we have to start the treatment and should go for the CTP mainly. So when it comes to parenteral anticoagulation, we can use low molecular weight, unfractionated heparin, and fundoparinax and novel oral anticoagulants. So fundoparinax and low molecular weight heparin is preferred due to low bleeding, low risk of major bleeding, and heparin-induced thrombocytopenia. Unfractionated heparin usually restricted patient when hemodynamically unstable, requiring primary reperfusion or severe renal impairment or severe obesity. Then today discuss much about NOACs, also novel oral anticoagulants, dabigatran, apixaban, edoxaban, rivaroxaban. Those are examples in trials. They show non-inferior to combination of low molecular weight heparin plus antibodies. So we can think about, but the problem is it is very much expensive and not readily available. Warfarin, vitamin K antagonist, it should be combined with the low molecular weight heparin when they are going for anticoagulation at least for 5 days. And we have to do the INR for, if it is therapeutic, for 2 consecutive days. between 2 to 3, then you can stop low molecular weight heparin and continue warfarin. With the anticoagulation, if patient is having high risk features or hemodynamically unstable, we have to think about reperfusion treatment. That it can be done pharmacologically as well as mechanically. So, usual method is pharmacological reperfusion with thrombolytic agent. It will make fast improvement because obviously mechanical obstruction is released with the thrombolysis. It can be used within 48 hours. If so, it is more beneficial, but we can use if patient is symptomatic until 14 days. The bleeding is the most problematic thing with the thrombolytic agents. Alteplase is the most commonly used thrombolytic agent. It is fibrin specific. Streptokinase also can be used if it is not available, but it is not that fibrin specific. So outcome will be low compared to alteplase. But we have to think about contraindications. There are absolute contraindications listed there. However, if patient is dying, nothing is absolute. So we have to think if patient is dying, we have to think about thrombolysis. If other modality is not available, and should ready for the management of the complications like bleeding, maybe patient just after the surgery having pulmonary embolism, we can't access for the mechanical thrombus aspiration or anything, then we have to think about thrombolysis because otherwise patient will die. We can't protect anything with this absolute contraindication. Then as I mentioned, percutaneous catheter-directed treatment. It is mechanical reperfusion, it is called. So we can access the pulmonary artery through femoral vein to IVC, to right atrium, to right ventricle and to pulmonary artery. Then we can fragment the thrombus and aspirate if possible. But the most promising thing is we can use a catheter and give a thrombolytic agent in situ. It will be low dose of thrombolytic agents and it is given topically and it is more effective. Then surgical embolectomy also can be done if the facility is available. Mainly this mechanical thrombolectomy and surgical embolectomy, these things done if the thrombolysis is failed or if contraindicated. Then multidisciplinary pulmonary embolism teams. This is emerging in USA and it is giving promising results. That is called PERS, Pulmonary Embolism Response Teams. Cardiologist, pulmonologist, hematologist, vascular medicine, anesthesia, intensivist, cardiothoracic surgeon and interventional radiologists. All these people are involved there and enhance the clinical decision making and treatment. Then Vena cava filters also we can use. It is actually mechanically obstruct the embolization from the deep veins. It can be used when the anticoagulation is contraindicated or patients having recurrent pulmonary embolism. While on anticoagulation, it got its own complication. This ESC guideline I just mentioned that it is recommended that anticoagulation with unfractionated heparin, including weight adjusted bolus injection, initiated without delay with the high risk patients. I discuss these things. So this is a risk adjusted management strategy for acute pulmonary embolism. So when patient is coming to the ETU, we can first anticoagulate, then look for the hemodynamic instability. If it is there, patient directly go to the high risk category. If not, we have to assess with the above mentioned tools about right ventricular dysfunction and other comorbidities. Then we can categorize to high, intermediate and low risk. If it is high risk, should go for the reperfusion directly and hemodynamic support. If it is intermediate, we have to observe patient cautiously whether the patient is developing hemodynamic instability or hypoxemia. Then if it is necessary, we have to go for the reperfusion strategies. If patients have low risk, very low risk, we can send the patient home with oral anticoagulants, mainly if NOACs available. Then once we manage the acute condition, we have to think about chronic treatment and prevention of the further recurrences. Once patient develops pulmonary embolism or DVT, the patient itself has twice as high risk compared to other person to have another episode. So, anticoagulation should be continued at least 3 months before termination. Then the recurrent risk itself depends on the background of the index pulmonary embolism case. If patients have reversible risk factors or major risk factors or transient risk factors, then recurrent risk is low because once we correct the risk factors, will be okay. But absent of these things, if there is no risk factor, the recurrent rate is high. Other than that, hereditary thrombophilia and that lupus anticoagulate, antiphospholipid syndrome, young patients with family history will need lifelong anticoagulation treatment. Then we have to think about anticoagulation related bleeding risk also, and we have to we can think about vena cava filters. There's high risk. So comorbidities like advanced age, previous bleeding, anemia, active cancer, these things will determine the continuation of bleeding, anticoagulation. So with patient with cancer, acute cancer with pulmonary embolism, we have to think about anticoagulation. Their low molecular weight heparin should be considered for the first 6 months over warfarin. Then it should be continued beyond 6 months or indefinite period until the cancer is cured. Then with the pregnancy, patient will present with a pulmonary embolism because it is a procoagulant stages. But the problem is the symptoms with pregnancy will overlap the symptoms of pulmonary embolism, dyspnea, fatigability, like. And D-dimer also will be persistently elevated during pregnancy. So negative, if it is negative, we can happily exclude, but if it is positive, it is difficult. In pregnant patient with suspected pulmonary embolism, we have to, as patient, start the treatment first, then go for the evaluation. Chest X-ray, better to do, they advise to do the chest X-ray because they can exclude other possible causes. Then can do ultrasound, DVT scan. If it is positive, we can go for the anticoagulation without going for the CTPA. If it is negative, then we have to think about go for the CTPA or VQ scan preferred, but the problem is it is not widely available to diagnose. Then long-term sequelae of pulmonary embolism. Once they manage the patient, send the patient home. Usually they say patency of pulmonary artery bed restored within first few months. So follow-up CTPA is not recommended. Minority of patients will have chronic thromboembolic pulmonary hypertension. But the problem is large number of patients will come with persistent dyspnea, poor exercise performance, etc. For that, should patient manage efficiently with good rehabilitation of post-op patient and should treat the other comorbidities and behavioral education, etc. Excuse me. So when patients having persistent symptoms, mainly dyspnea, poor exercise tolerance, we have to look for the comorbidities like advanced age, previous cardiac surgeries, high BMI, smoking, and higher systolic pulmonary artery pressure on admission. And when patient is discharged, patients have residual pulmonary artery pressure. These are the conditions conditions causing this post pulmonary embolism, long-term persisting symptoms. So we have to address them and, if possible, should correct. Then another entity, I will discuss it briefly, the chronic thromboembolic pulmonary hypertension. So it is due to chronic thromboembolism. Then that usually vessels will be recanalized with time, but some people will tend to get the chronic thromboembolism, will lead to chronic pulmonary hypertension. So these patients will present in advanced stage with heart failure, with systemic congestion, maybe right heart failure, and the problem is symptoms are non-specific. So it should be diagnosed. Mainly, once diagnosed, we have to continue the anticoagulation for 3 months and should reassess. If the patient is having pulmonary pressure persistently after 3 months, then we can diagnose the patient. These are the causes for chronic thromboembolic pulmonary hypertension. So in summary, pulmonary embolism is itself carry a very high risk for mortality. So prompt suspicion, diagnosis and early treatment is very important. So early reperfusion whenever possible should take the decision promptly. So should assess the possibility of recurrences and the prevention, the DVT prophylaxis in the ward patients. So we should not forget about these things. So we can happily prevent more volume of patients of pulmonary embolism with small efforts. Thank you.